Welcome to the first VHIN webinar for 2024. Ko Barry Milne aho, he manataki aho ki Campus Research Centre ki Waipapa Tamararo. So my name is Barry Milne, I'll be the chair for the day. I'm the director of the Campus Research Centre at the University of Auckland, and I'm delighted to welcome Lisa Underwood along today, who's just got her slides back up again, who's going to be talking a little bit about research that I've also been involved with about chronic conditions in families and the impact of chronic conditions on family members. Lisa is a senior research fellow at the Campus Research Centre here at the University of Auckland. She's a psychologist with an interest in neurodevelopmental disorders and also rare disorders. She just got a grant to study rare disorders, and she worked for many years. Actually, like myself, she attended the Institute of Psychiatry in King's College London, and also like myself, she worked on the Growing Up in New Zealand study for a while. So she worked on it for 5 or 6 years after coming to New Zealand. Over to you now, Lisa.
Thanks, Barry. Kia ora. So yeah, I'm Lisa Underwood, and I came to New Zealand from the UK in nearly 10 years ago now, and I've been working with, I guess, on health data and data on children's outcomes since then. I started working at Campus, I think it was around March 2021, and this is the first project I did that was based on IDI research, and it's taken quite some time to get everything together, but it's finally coming towards the end of the project, and so I'll be sharing some of the challenges we've experienced in using the IDI to look at families and to look at long-term health conditions, and some of the kind of initial findings that are due to be published soon. So I'll get to those towards the end. So we had a really large wide team of researchers working on this project. It was funded by the National Science Challenges. So I'm just going to give a very brief overview of the IDI, because I'm thinking most people come into a VHIN seminar will know what the IDI is. So essentially a very large national research database with microdata about people and households within New Zealand, managed by Stats New Zealand. So everything that we do with the IDI is done with Stats NZ approval for the initial project. Everything that comes out of the IDI is checked by Stats NZ to ensure confidentiality and safety of the data. And there is, as you probably know, a huge amount of data within the IDI. So it's not just kind of government agencies that are providing data. There's quite a large number of surveys within the IDI. Also includes census 2013 and 2018 data, and fingers crossed soon 2023 data, and some small amount of data from NGOs. And the massive advantage of the IDI is that we can link data for individuals and to some extent for families across different sectors. So as the example here, we can link education records to, say, hospital records. So the IDI is constantly updated with new data as it becomes available. And the reason that data becomes available is because a large amount is administrative data, so data that's collected about us while we're in New Zealand, and we're interacting with a huge range of services that kind of collect data as they're going along to either record interactions or to kind of be able to evaluate or assess those services. And we're really lucky in New Zealand to have this resource that we can access and use in research, but that does come with some caveats. You know, this is largely, apart from some of the census and surveys data, administrative data, so it's prone to some biases and some errors that we really need to be careful about. And really it's a record in terms of administrative data of service interactions, which makes it somewhat difficult when we're talking about, you know, rates of health conditions, as I'll discuss. And so there is a very large number of people in the IDI. So anybody who's ever been captured in any data source, and these are listed here. So that's about 70 million people. Anyone who's ever been a resident in New Zealand, that's what we call the spine. So that goes back. I'm not sure actually how far that goes back now, but it's larger than the current population because it includes people who have since died or left New Zealand. But it's that spine that we use to link different data sets. So it's really important. And that there's a lot of work obviously that goes on behind the scenes at Stats NZ to ensure the kind of accuracy of that linkage between those different data sets and to the spine. I've just realised my current resident population is a little bit out of date. I think that's updated every few months. But from 30th of September 23, we're at 5.269 million. So we're really talking about, yeah, quite a lot of people. So on to the project. This, as I've said, was a large group of studies really that was focused on family and whānau and how we can carry out family and whānau research. And large parts of the project were about the impact of chronic health conditions on family and whānau. So we had a wide group of institutions involved, both in New Zealand and Australia. Some really interesting work has come out of, in particular, Offa's study. So Offa Dewars did a more qualitative study in the Tokelauan community, looking at carers and how caring impacts family members. That's the main project I've been involved in, haven't been involved in some of the other projects so much. The main project I'm involved in is this impact of chronic disease or long-term health conditions on family and whānau. And we've ended up with a few studies coming out of that. I haven't actually listed them all here, but we've got a study from the University of Canterbury, Otago, looking at the impact on family of having an elderly person with a chronic health condition. We've got a project from the University of Queensland looking at the impact on partners' income if the other partner has a stroke or experiences a traumatic brain injury. And then I'm involved in a study where we're looking at the outcomes of parents whose first child has autism, how that impacts their employment and labour force participation. And then my main part of the project has been really putting all the data sets together to provide to people, for people to analyse the data. And then I'm going to be focusing on the impact of having a chronic condition within the family on children. And as a result of that project, we started to look at young carers, which I'll talk about a bit later as well. So just to give some background, this makes it look quite simplistic when I look at it now, but really the key sources of data that we wanted to bring together for the part of the project I'm going to be talking about were that population and demographic data. And it really, at the moment, the best data sets we have for family-based information is really the census. We focused on census 2013, partly because the family data is rated as pretty high quality, but also because we're looking at longitudinal outcomes. So we wanted to start with a base cohort of families from the 2013 census and look at what happens to people within those families and what happens to those families as a whole over time. So we're going to be able to go, up to probably around 2021 to look at long-term outcomes. But some other parts of the project and I'll talk about this in a moment, have looked at kind of who's in the current or in the estimated resident population at a particular time point. But largely I've been looking at that census 2013 data. And then we've linked that data to health data. So Ministry of Health data. I've listed the data sets here briefly. I'll talk about those in a bit more detail. And going forward, we'll also be linking to education data, so education of outcomes for children, things like attendance at school, qualifications, what happens to people, young people when they leave school. As I've said, we're linking to labour force participation and income. And then I'm also doing some work looking at kind of overall family well-being. So I'll be linking to a lot of different data sets. And we've really taken quite a broad but still restrictive definition of long-term health conditions. So we started out, I believe, thinking about the long-term health conditions that are included within the Ministry of Health's chronic conditions data set, which was collected. It hasn't been updated since 2017. So the idea for us was to kind of update that data set using the same search algorithms. But we really wanted to widen it. So in addition to the chronic conditions that are within that data set, we added mental health and behavioural conditions. And so Nick Bowden, who's done a lot of work on this, and has provided the search algorithms for those conditions. And we also added dementia because that wasn't previously included. So obviously one of the first challenges was how on earth we go about identifying these long-term health conditions, because it's not easy when you're looking at a large number of conditions and you're trying to search a broad range of data set. So I've done a bit of work. I think my table here might be a little bit out of date and I need to update this, and I think there's some work to be done around coverage within these individual data sets, and I'll talk a bit more about opportunities for that at the end. But this is a brief literature review, by no means systematic review, of some of the previous research that's used the IDI to look at chronic conditions or long-term health conditions within New Zealand. So you can see a really broad range of conditions. Some overlap with our range of conditions. Probably the broadest range of conditions comes from Blakely. And they also included some of the broadest selection of data sets. But as you can see, their age range for that study was adults. So it was based on those aged 25 to 64. So didn't include those older individuals and didn't include children and young people. And I think you can see from this that there's lots of overlap between these studies. Some are broader than others, some focus on one particular chronic condition, but I think and quite often they're focusing on particular groups of people, and it's usually either adults and or children, whereas whether this was a good idea, I'm not sure in retrospect, but we decided to focus on everybody, and we decided to focus on a broad range of long-term health conditions and to search kind of as many data sets as were useful. So I think I've actually missed one out in this list here, because we also included ACC in our searches, and that was actually something we added later on when we realized that really traumatic brain injury wasn't captured well within hospitalization data, because not everybody is hospitalized if they experience a TBI, so traumatic brain injury. So we did kind of, as we went through the study, started to expand. So I think we also included mortality, although that doesn't factor in the data I'm reporting today, but we have looked at mortality data sets to see, find individuals who've died from these chronic conditions or who had these chronic conditions when they died. So our first step really was to gather the search algorithms. And so, as I've said, for most of the long-term health conditions, we use the criteria developed by the Ministry of Health for the chronic conditions data set. But we amended it somewhat. So for diabetes, we made some changes that incorporated the virtual diabetes register methods. So there were some slight changes there when we looked at how we collect lab test data, for example. And then for mental health and behavioural conditions, we used the Social Investment Agency and Nick Bowden's work. So again, really broad definition of mental health and behavioural conditions. So it encompasses kind of mental health conditions that you'd expect. So more common ones like depression and anxiety, also more severe conditions like psychotic disorders, also includes behavioural disorders, so ADHD, autism spectrum disorder, conduct and behavioural disorders. The key things we didn't include, I guess, in those are substance use disorders. So they weren't included in our definition. We also didn't include intellectual disability, but I think, or we didn't include self-harm either. The other addition was the dementia searches, and for that we used the searches that were developed by Walesby. So again, pretty broad range of search criteria and data sets that we searched. And we also, I think I mentioned, expanded the original searches that the Ministry of Health developed for traumatic brain injury. We used what's kind of referred to as the Ministry of Health criteria for traumatic brain injury. So it's quite a restricted set of ICD codes. But when we looked at Horsepool, the Horsepool study, they had found that using an ACC criteria, which has a much wider range of particularly ICD codes, identified a lot more people. So we incorporated that wider range of ICD codes, and we also searched ACC for records of traumatic brain injuries. So just wanted to kind of point out some of the challenges we came across. The first was that case identification, really kind of nailing down those definitions, making sure they were still relevant, making sure they still worked within the IDI, choosing which we would implement. And I think that probably took some time, and it was a moving target in some ways that we kept adding to. We had to stop that in the end, but I think we've landed on a really good set of criteria for identifying conditions and a really broad range of data sets. So one of the main issues I had at the beginning was actually the sizes of those searches, particularly for pharmaceutical data, because pharmaceutical data includes every dispensing of a pharmaceutical medication for every individual. So as you can imagine, if people are being prescribed medication quite regularly, then that adds up to a lot of data. So those searches did actually tend to take quite a bit of time in the IDI and were a bit more difficult to manage. And the other thing was just kind of keeping track of merging those data sets, because I wanted to be quite comprehensive in how I did that and make sure I knew exactly how we had identified each person's health condition, so which data set we'd picked it up from, so that we could kind of understand some of the coverage within the data sets and understand which data sets had been more or less useful for our searches. And then we had some anomalous data that we had to deal with. So started to realize that we had, for example, there were some people whose age, according to the census and according to the personal details data within the IDI, so it really looked like they were actually, well, according to the IDI, they were yet very young people. But when we linked to their health data sets, they had a dementia diagnosis. And that could be for a number of reasons. Could be a linkage error, so some issue there of linkage between the data sets. It could be an error with the information that's been entered at the kind of health service end. It's impossible for us to know, but it did leave us a dilemma about what we do about that information, because it clearly there are very, very few people who receive a dementia diagnosis under the age. We've used a cutoff of 40. It does happen that people younger than that receive or have early onset dementia, but we use that as our cutoff. And so we had to kind of find ways of dealing with that. The other one we used for that was gout. So we said that we excluded anybody under the age of 20, or we didn't exclude them. We discounted any gout diagnosis that was received by a person when they were under 20. For dementia, it was 40, and for COPD, it was 20 as well, because that's not something that's diagnosed in children. The chance if a child does have a that was mainly, we identified those people, I think, mainly through pharmaceutical data. So that would mean that they had very severe asthma. So they were receiving medication that's usually prescribed for COPD for very severe asthma. So that led to a small amount of data that we had to kind of discount or not include. But I think on the whole, the coverage we have for that, those data sets, for the health conditions data sets, is pretty broad, albeit hasn't included quite a few important conditions that we might think about within New Zealand, and I'll talk again about that at the end. So that was the first challenge for me, was identifying these or identifying individuals who have experienced these long-term health conditions. And we've got a manuscript that's currently under review. It's taking a while to get through, but Andrea Tang has used the estimated resident population as at June 2018 to look at who within New Zealand has one of these, or according to the IDI, has one of these long-term health conditions. How does that look across different demographic groups? So looking at age and ethnicity and the living situation that people are in. Are they living alone? Are they living in within a family? What areas they're living in terms of deprivation and their functional impairment. So within the census, so that we use census 2018 data, we have those questions about different types of impairment. So mobility, communication, memory. I can't remember the other one, but there's a 5, I think, different activity limitations, and we've looked at how that kind of correlates, I guess, with diagnoses of health conditions. So that should be hopefully published soon. So that was looking at all individuals within New Zealand. So we had a really large sample for that, 4.79 million, that estimated resident population. But as I've said, my part of the project was really looking at families. And again, when I started thinking about this, thinking about how the experience of long-term health conditions within families might affect that family as a whole, and affect individual family members. And I started to look at some of the existing research that has used family level data within the IDI. So there has been quite a lot of family level data done using census in particular, because as I've said, that gives us a really good quality unit of analysis in terms of family, but it is quite restrictive. So within the census, we have what the census calls nuclear families. So that is at least 2 people who live together. They may have a child, or they may be 2 people who live together without a child. At least one of those people should be age 15 or over. So that's that kind of nuclear family. And you can, within the census, there are those families have a unique family ID that you can use to identify who's in the family and therefore link to other data sets. But there are also extended family IDs. So this might be if another family member, say a grandparent or parent of the parents, lives with the nuclear family, or perhaps a sibling of the parents lives with the nuclear family. It could be 2 nuclear families who live in the same household. It could be more than 2. So there's quite a lot of variation, but not much attention's been paid to those extended families. And when I was thinking about how people within families might be impacted, I realized that just focusing on nuclear families is not going to kind of incorporate, particularly if there's an older person living within the family. So I've just done a brief summary here, again, not systematic, but just some of the IDI research that looks at families. So this first one that Gath and Brycroft is really useful about whether we can construct households and family information not using census data, but purely from the administrative data. And at the time that they carried out kind of that evaluation, they really concluded that census data is the best way to look at families using census identification. I know that the Stats NZ are working on constructing household kind of units with using administrative data, but for family data, really, it seems that the census is going to be the best way to do that. There's been some work going on tracking well-being, looking at how well-being varies according to family types, and lots of work on income and income mobility, and quite a lot of work mainly evaluating families package. But most of this research doesn't address those extended families, so it's very much based on the nuclear family, without really considering who else might be in that family. And so after working out how to identify those long-term health conditions, the next step was to work out how to define our families in the study. And you can see that on the right-hand side. So what we've done is the vast majority of families within the IDI are that nuclear family. So I think we've identified 41 different family types. The biggest number are, I think, 2 people with children. And so if there's nobody else within that family doesn't have an extended family ID, there's nobody else linked to it, then we've obviously maintained that as a nuclear family. And then we have, sole parent families, we have couples without children. But what we've then done is if individuals had any extended family members that were identified using that extended family ID, we've grouped them all together as one family. So what would normally happen is, even if you had 2 nuclear families who were living together in the same household, we can link them using their census extended family ID. But generally, within a lot of research, they're kind of looked at separately, not as a family unit. So say if we were looking at their income, it would be the income of one nuclear family and the income of the other nuclear family. But we've included all families that are living together, identified as being in the same extended family together. And so what we've ended up is fewer families, because we've grouped more families together, but generally we have more people within those families. So I think within some of our family units, we've got up to 5 nuclear families living together. And I'm trying to remember I think we've got up to 20 people within a family. So it's a really broader definition of family, and includes much more people. So it will be a wider range of individuals, from the very young to older individuals. That came with, I think in general, identifying families using the census data comes with some challenges. So one is when we start linking those families and individuals, particularly individuals in those families, to other data, and that's where we come across this missing data. And there's a couple of big reasons why that might be. So for the 2013 census, if a person wasn't present in their household on census night, some limited data was collected about them. They were given an SN, they weren't given an SNZ UID, that's the key thing. But if they were in a family, that family or extended family identifier was assigned to them. And so that allows us to account for those absentees in terms of family size, and you know, the number of, I think we can work out the number of children, number of adults in a family, but those absentees weren't repatriated to their home as they were in the 2018 census. So they don't have an SNZ UID, that unique identifier that we use to link across data sets. And so we can't link them to the spine. We can't really tell anything else about them apart from some limited data that's included in the absentee tables. But when I was constructing the families, thought it was really important that we did try to incorporate those individuals so we could, to some extent, quantify who was missing, and allow us to really work out the true, not necessarily true, the most accurate estimate of family size. Of course, even if people were present on census night and have an SNZ UID, they might not be actually on the spine, so we might not be able to link them to any other data sets. And there's also some issues just in general with the census. So in census 2013, I think about 2.6% of individuals couldn't be placed within a household, and there's a range of reasons that might be. I think there's some work that's come in terms of the kind of numeration of the census that explains who those people might be. But there's a number of households that just, or families that just aren't accounted for by the census. It is a small amount, but there are probably some biases in terms of who the individuals are in that family. So even once we had kind of incorporated all this information, we included some absentees in terms of family size. We included individuals who weren't on the spine. But what we end up with, even if we look at all those people, we find some anomalies again. So what I found is I ended up, even if I took everybody into account, there were these one-person families. So there was a family ID within the census data, but when I looked at the number of individuals with that family ID, there was only one person. There could be a number of reasons for that, and we unfortunately that meant we kind of had to exclude those families. There were also instances where there were no adults in the family. So in the census 2013, as I've said, the definition for them of an adult is someone age over 15, and there should always be at least two people, one of whom is over 15. Again, when I looked at the individuals in our families, there were some families that didn't have anybody over 15. And that becomes even more complex when you think about whether we have complete families who are present in the household and who are linkable to the spine. So we had to do a bit of work on deciding, you know, how we would define the inclusion criteria for our families to make sure that there were people in those families that we could link to the spine. So yeah, a few challenges there, but again, I think we've wound up with a really strong data set that encompasses a broader range, a broader definition of families than we've typically see in family research, particularly family research that comes out of the census. And we've tried to include as much information we can on those families that has incorporated that absentee and kind of individuals that aren't on the spine when we look at who's in those families in terms of their composition, I guess. So after my initial searches for the long-term health conditions and those searches for the New Zealand families, I was able to bring those data set together to answer the main questions for my part of the study, which is how many families in New Zealand are affected by the long-term health conditions that we've looked at. And eventually soon I'll be looking at what the outcomes were. So just in terms of who are what people were in families in the census. So we identified just over 3 million individuals who were living in a study family or living in any family. Almost 1 million of those individuals were children. So in our study, we've defined children as those aged under 18, and that equates to just over 1 million families. We've got a proportion who are multi-generational families. So we identified those using, the only way to identify those was using extended family type variable. Around half of our families included at least one young people, and as I've said before, the family size was really wide ranging. So from 2 to over 19, we had up to 5 families living together. And ultimately, what we've found is a group of families. So out of that, just over 1 million, around 60% of New Zealand families in 2013 were affected. So they had at least one person within the family who had at least one of the long-term health conditions we're interested in. So 3 in 5 New Zealand families experiencing long-term health condition, and about 1 in 5 families where more than one person has a long-term health condition. And of course, within that, there's some, we will be able to look at some more nuanced data about how many people within the family have more than one long-term health condition. So we're interested as well in multi-morbidity and how that might impact families. And really high rate of long-term health conditions among those multi-generational families. So the proportion of families affected by long-term health condition really increases as we include multi-generational families. And I think largely that will because those families tend to include older individuals, and we know that a lot of these health conditions are more likely to affect older individuals. So you can see here that by far the highest identification of long-term health conditions was mental health and behavioural conditions. And that was largely because we, for this project, included that pharmaceutical data, because if you remember looking back to the data sets that we've used, they do tend to be focused on secondary care. So hospitalizations, specialty mental health services, and don't address individuals who only get seen by primary care. And we know that a lot of people, particularly with mental health and behavioural conditions, will only receive care from their GP. So pharmaceutical data is a good way of kind of identifying those people, but it really results in very different findings for mental health and behavioural conditions. So the previous paper I talked about, Andrea Teng's paper, found a much lower rate for those mental health and behavioural conditions because it didn't include pharmaceutical data. And as you'd expect, fewer people are affected by the more severe, I guess, conditions. So dementia and stroke. But we have quite a large amount of people who are affected by, particularly by diabetes and traumatic brain injury. So that's the kind of family unit. So when we look at the individuals within those families, we've got almost 2 million people who have a long-term health condition themselves, or they live with a family member who has a long-term health condition. So that's 3 in 5 people who live within a family, not necessarily 3 in 5 people in New Zealand, 3 in 5 individuals within families. We found around 10% of children had a long-term health condition themselves, which is much lower than we would see for the older population. So because a lot of these conditions develop over the life course, we have a fewer number of children with a long-term health condition, but around half of children, and obviously most children, the vast majority of children in New Zealand live within a family. Around half of those children have a family member with a long-term health condition. Around 130 of those children are aged under 5. So being experiencing living with a long-term person with a long-term health condition from a very young age. we see quite differing rates for different ethnic groups and different patterns within different levels of area level deprivation. So we can see that these kind of, I guess they're not really trajectories, but these patterns of how the proportion of families affected or who experience a health condition changes according to whether they live in an area of low deprivation, so that it's a very, you know, an affluent area, or an area of high deprivation. And we use total ethnicity for our measure of for our classification of ethnicity, so people could identify with multiple ethnicities. I think in this, what we've said is that, I think this is this graph, although this might be individuals, but we've had some debate in around whether we consider family ethnicity. So we have in some of our manuscripts said that if at least one person within a family identifies with a particular ethnicity, then that family incorporates that ethnicity. So it can get a bit confusing. And this data is very I guess restrictive in terms of the classifications of ethnicity, but we have extracted data that looks at more a level 2 ethnicity. So individual Pacific ethnicities, individual Asian ethnicities, and separating out Middle Eastern, Latin American, and African. I'm probably not going to have time to talk about the young carers research, but we're doing a side project where we've looked at who within the census in 2013 identified themselves in some way as being a carer. And we've been looking at who among those people are these young carers. And ultimately, my I'm going to skip through these. My goal is to look at who those young carers are and how being a young carer impacts them. So my work going forward is to look at how does having a person with a health condition in your family affect a child, and how does it affect the family as a whole. So I'm going to need to do a fair amount of work on family well-being. I think what we've been really interested to find is really just how many families are affected by illness and disability, and that perhaps there's opportunities there to provide wraparound services, to recognise the needs of those families, to kind of provide a less individualistic approach, I guess, to health service provision, and particularly to recognise the needs of young people. And just in terms of really the main reason I'm here is to kind of put a shout out to anybody who's interested in this research, to get in touch with us, because we've got so much data. So in terms of opportunities for research in the data we already have, we've got a large amount of data on how we identify long-term health conditions within the IDI, how we measure family well-being from using different frameworks. And I have a large amount of data on Māori, Pacific peoples and Asian peoples, and outcomes for those people and families, that is already collected and is in need of analysis. But also we are hoping to expand to look at some other long-term health conditions, so particularly substance use problems, conditions we know in particular affect New Zealanders, so chronic kidney disease, liver diseases, and as Barry said, I'm really interested in rare disorders, and have some funding to look at rare disorders within the IDI, which is going to be really exciting. Release schedule for the census says individual and dwelling data scheduled for August 2024. A question here. I wonder if you'll be able to tell how many of those families are actually caring for a younger adult with a long-term health condition. For instance, parents in their 60s with a 30-year-old son at home. Yeah, I think it's the the identification of who is caring for whom is really tricky, and I don't think something we're going to be able to unpick as part of this project, because although we can identify whether somebody says that they are providing some care or help to a family member within their household, it's impossible to tell who that family member is. So we could identify who within the family has a health condition, but with so many individuals experiencing health conditions, it's very difficult to work that out, unfortunately. Slide 17 does not control for differences in age distributions of different ethnic groups, which is something that's really important, and that we'll be doing going forward, because we know that the demographics within those different ethnic groups and within different socioeconomic circumstances vary a lot, and so it's going to be really important to take that into consideration. What share of those in the Asian and Malay group are migrants? Again, really important. Something we'll be taking into account is whether individuals were born in New Zealand. Again, that's going to be super tricky, because there'll be some families where everybody was born outside of New Zealand, some families where some members were born inside of New Zealand and outside of New Zealand. But I think there will be, I think when I've looked at some of the data, particularly on Latin American individuals, according to our data, appear very, very healthy, appear to have really low rates of health conditions. But I suspect that is largely because they tend to be, those individuals are younger, and that they need to be healthy in the first place in order to be able to come to New Zealand. So it's going to be really important to take into account. We've got a question from Jean about the long-term health conditions don't include, there's a wide range of conditions that we haven't looked at. So Jean's given some examples of cerebral palsy, muscular dystrophy. I mean, I think that the scope is almost endless for the conditions we include. We have included, and we had to, narrow that scope for this project. Natalia Boven, who's done some really important work on family income, she's interested in complex conditions. So she's doing some work at the moment on multiple sclerosis, and is interested in expanding that to some other complex conditions. Nick Bowden's doing a lot of work on neurodevelopmental conditions, and I guess related to that, conditions that are associated with, intellectual disability or autism or ADHD. And I'm doing some work, as I said, on rare disorders. So that will encompass a lot of long-term health conditions. Probably, I think cerebral palsy is not classed as a rare condition, but there will always be conditions that we've missed. I think it's up to I guess researchers to prioritize the conditions that they're interested in, and it's what you can get funding for ultimately. I think it's easier to get funding for some of these much more common conditions, because they affect so many individuals. But we know there are lots of individuals collectively with less common conditions, and in some cases, because those conditions are less common, they have broader impacts, because it's much harder to negotiate the health system and other systems, much harder to get a diagnosis than some of these conditions. Barry, did you want to say anything about the kind of study and the wider part of the study? I think
only just to reiterate what you said, that we're now, and you particularly are moving on to looking at the impacts on the other members of the family, yes, of being in a household where someone has a chronic condition. And you did mention the work that Martin O'Flaherty and others are doing out of University of Queensland, looking at the impact of TBI and stroke in one member or partner on the partner's employment and income outcomes.
Yeah.
So that's being drafted now. So just work in that area, and you're going to move on to looking at the impact on children.
Yeah, so I think that's going to be, I think, I mean, I say it's going to be relatively straightforward. I think that the key challenge I'm going to have with that one is kind of those covariates. So how do you take into account how many people in the family have a condition, which condition they have? We've got challenges around how we kind of identify individuals who have perhaps more severe conditions, because within these conditions, somebody may be affected very mildly in terms of their disability or impairment they experience, whereas others will be affected more severely. So it's going to be those the way that we do the analysis and how we take those kind of covariates into account that I think is going to be tricky. And also I've started doing some work on family well-being and how we measure that, and again that's actually very it's very difficult to achieve within the IDI. It can be difficult to achieve a kind of holistic measure of well-being, and I think I'm particularly interested in whether we can validate some of those objective measures of family well-being against more subjective measures that are in the say like the health survey.
So thank you Lisa, and thank you all for joining.